Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Well, hello everybody, and welcome to this LE&RN online symposium. My name is Louise Koelmeyer, and I'm here today to present on the topic implementing translational best practice models of care in lymphatic disorders. I'd like to firstly thank the team at LE&RN who invited me to participate in this symposium, and there will be time for questions at the end of the presentation, and I ask you to put any questions you have throughout the session in the Q&A box in the bottom of your screen, and we will have time to answer those at the end. And I'm very happy for people to contact me after this symposium for further discussion. So I just acknowledge the amazing corporates who have supported this LE&RN series. And I wish you all a very happy World Lymphedema Awareness Month, the month of March. We've started Lymphedema Awareness Month, and this is a great way for us to connect and network across the world. And I know there's lots of activities planned by LE&RN for next Monday, March the 6th, and we certainly hope to be part of those from abroad. So, as I said, my name's Louise Koelmeyer. I'm an occupational therapist and a lymphedema therapist, and I've been working in lymphedema for over 30 years. Yes, I know I don't look that old. I started when I was 5, but I'm very excited to be presenting, and I guess having time to reflect on my experiences as a lymphedema clinician, as a researcher, and as an educator. I work at the Australian Lymphedema Education Research and Treatment Program, a long name, which is called LE&RN. So whenever I mention the word LE&RN, that's the name of our program in Sydney, Australia. And I welcome you to visit us anytime. This is my hometown where I am. That's our famous Sydney Harbour Bridge and the Opera House. And this is the clinic and the hospital that sits on Macquarie University campus. We're a health science academic institution offering undergraduate and postgraduate courses in various health sciences, a medical program, a physiotherapy program, psychology, and this is where our lymphedema program also sits within the Faculty of Medicine, Health and Human Sciences. You'll see our beautiful beaches. If you haven't been to Sydney before, you would be most welcome to join us. We have some beautiful wildlife and animals, and I live in the eastern state of New South Wales in Sydney. So feel free to come and visit us at any time. So as I've said, March is a really special time for us all working in the area of lymphedema and lymphatic disorders to raise the profile, raise awareness about this very important condition. Interestingly, today for me in Sydney, it's about 26 degrees Celsius, which is about 79 degrees Fahrenheit in the States. We've just gone into autumn or the fall, and after having a really lovely summer season. I know in the Northern Hemisphere, you're the reverse to us and at a different time of day as well. So welcome. I have acted as an education consultant to ImpediMed, and this is what I'd like to present today. So I'm going to give an overview of our LE&RN program at Macquarie University. I'm going to share some of my observations of my 30 years working in this area, and then I'm going to be looking at implementing translational models of care and how we do this down under. I'd also like to then talk about how we integrate our LE&RN indocyanine green lymphography research outcomes into clinical care, and also how we've integrated our research outcomes into our education framework. So who are we at LE&RN and what do we do? So LE&RN is a multidisciplinary national and international flagship program at Macquarie University, and the 3 names in our program are the 3 arms of our program. And our mission is to deliver high standard, personalised clinical care, evidence-based education, and innovative research in the fields of lymphedema, lipedema, and other chronic conditions. In education, we offer a micro-credentialing program where we actually train health professionals to become qualified, accredited lymphedema practitioners here in Australia and New Zealand. And we're also involved in teaching Macquarie University students in the MD program and also physiotherapy program. We're involved in various research programs, both externally funded research studies and in-house investigator-led studies. And we have an amazing multidisciplinary clinic. And I'm going to go into more detail and share with you how these three arms link and how they're translatable and integrated between each other. We're really proud to be a LE&RN Centre of Excellence, and we're very grateful for the support that LE&RN has given us over the years since we became a Centre of Excellence in 2020. I'm very grateful also that being on the other side of the world, to many of you, we have developed very strong international research collaborations. We love working with people and other people who are interested and motivated to want to help those living with lymphedema and lipedema and chronic edemas. And so I'm really grateful for these individual academics and their teams for inviting us in some cases or including us in collaborative partnerships. And interestingly, Drew Singhal in the Boston Lymphatic Centre, we've got a meeting tomorrow, a combined MDT meeting. So we're trying to reach out and share so that we're not all living in silos. I think these days, with the impact of having virtual collaborations, internet access, we can do anything with anyone from all over the world. And I'm grateful for that. At Alert, we also have partnerships with corporate partners. I think when you're working in lymphedema, you can't manage a patient or teach a student unless you've got relationships with corporates. And we're very grateful for the strong partnerships that we have with our partner relationships. And we also have partnerships with other external organisations who have a cause and a mission and a vision to work in the area of cancer and lymphedema. And we're grateful to be working with all of these different organisations. So for the next 40 minutes or so, I need you to stay alert, come on the ride with me as I share with you my experiences of our Alert program and what we've achieved in the last 10 years, coming from a program starting in 2012 with 2 people and joining now to a team of almost 30 people. And as I look at this photo, I look at this young boy looking at a map of the world. This just helps me to observe the changes that have happened in lymphatic disorders over the last 30 years of my experience. As a new graduate occupational therapist and lymphedema therapist, I was often telling people the exact opposite to what I'm telling them now in an education role about lymphedema, risk reduction, and how we manage it. And that's because of the wide, extensive research that has happened internationally, particularly in the last 20 years or so. We know lots of resources go into breast cancer research or cancer research and survivorship, but lymphedema has often been secondary. Lymphatic disorders has been a little bit secondary. But I think it's been absolutely amazing, just the collaboration and the extent of research that has now been published in this area across the world. And I'm really excited to see where this is going to go in the next 10 and 20 years during my career. We know this is some photos of individuals living with lymphedema. People with lymphatic disorders impacts their life significantly, not only physically, but functionally, psychologically, and also financially. And we have different health services across the world offering different equity levels to people living with these conditions. And it's my vision that every individual who's at risk of lymphedema or living with lipedema or other lymphatic disorders has access to evidence-based, best practice management so that they can reduce the physical, psychological, functional, and economic impact on their lives. So this is our alert approach of how we manage individuals living with lymphedema. We very much thrive and have a person-centered integrated care approach. The individual living with this condition has to be at the center of anything we would do. We want to have a multidisciplinary program, a multidisciplinary approach, because bringing together individuals from different health disciplines will bring greater expertise, greater knowledge in how to look at this problem, and it will help us to guide the patient and interact with the patient to achieve their needs. We need to be involved in translational research, and I'm not at all dampening big, large clinical trials, randomized controlled trials. There's a very big, important place for those, and it's that work and that research that has brought us to where we are today. But I think also we need to be integrating our research into our clinical practice so that our patients can benefit from the start rather than waiting 5-10 years before some research studies are actually translated out into the community. And I think also we need to look at evidence-based education. I think sometimes our education models of care and delivery are based on myths and things that we learned from the past that perhaps are not so evidence-based. And I think we need to bring our education levels up to the same level as where we are in providing care for our patients. So I've got a couple of photos here of our clinic. Our alert clinic sits within our clinical space within Macquarie University. We have 6 treatment rooms, 6 consultation rooms where patients come in. They see our members of our multidisciplinary team. The patient is at the centre. We'd like to think our clinic is a bit like a one-stop shop, that the patient can come in and have access to medical practitioners who specialise in this condition. They can also see lymphedema practitioners, and we have lymphedema practitioners who are occupational therapists, physiotherapists. We have exercise physiologists, we have dietitians and psychologists who can see our patients. We have surgeons, we have imaging specialists, and all of this happens within this clinic building. We're fortunate to have a measurement room that we like to have all of our objective measurements taken. And this is my team. I'm very proud of this team and very grateful for every single member of the team and how they give 150% effort and commitment to the cause of enhancing lives of individuals living with lymphatic disorders. On the top row here, you'll see our medical team. We have 2 rehabilitation specialists who have extensive experience in this area. Dr. Helen Mackey has been working in this area for over 40 years. We have the guru, Associate Professor Hiro Swami, who's a lymphatic anatomy expert. We're fortunate to have 2 plastic surgeons who work on our team and an imaging specialist. So they very much help to lead and guide our team. On this row, we have 7 lymphedema therapists who are all working across our conservative and surgical clinics to enhance care for individuals. I have an amazing research team who are involved in translating what happens in our clinic in our publications and getting our results out to enhance and get positive outcomes for individuals. And we have an amazing support team. Our education team and our clinical admin team are absolutely amazing. We're also fortunate to have some honorary professors who have worked with us for many years now and continue to work with us in giving their wisdom, their advice and help in research and other areas of our program. And I'm very grateful to my colleague, Professor John Boyages, who was my predecessor as director of our program and a visionary in helping to guide our ALERT program. So what do we do at ALERT for our clinical arm of our program? We have 3 clinics in our program. We have a diagnostic clinic, which is medically led. Now, this diagnostic clinic is very much a clinic that we have patients who fly into Sydney from across the country and New Zealand for the multidisciplinary assessment. These are patients who are quite complex medical history and perhaps haven't even had a formal diagnosis made before. These patients come in and we have access to a variety of imaging if we deem it necessarily. We have access to MRI, lymphoscintigraphy, and indocyanine green lymphography. So the ICG is where these patients can come in and see in real time what is happening to their superficial lymphatic system. This has been amazing to visualize these lymphatics, both for our team and also for the individual patient and their family to see what is going on underneath the skin. Within this clinic, the patient sees a medical practitioner, then has measurements done by my research team, and then is seen by a lymphedema therapist to develop a treatment plan based on this multidisciplinary holistic assessment. In our conservative clinic, which is allied health-led, lymphedema practitioner-led, we complete full CDT treatment for those in the States, or CLT treatment, complex lymphedema therapy for those of you in Australia, where we assess and manage the individual and offer them all aspects of conservative management under a best practice guideline. We start our intervention right in the beginning, and it's our goal for individuals going through cancer treatment that they have access to a prospective surveillance and early intervention model of care. So a screening program from the time they're cancer diagnosed right through their treatment and beyond, in order to detect any subclinical lymphedema, intervene early to try to prevent the long-term development of chronic lymphedema. But as we know, there are still many patients out there who are living with chronic lymphedema, and this is where they're managed by our team in the conservative clinic. And then we have our surgical clinic, which is again a multidisciplinary team led by medical practitioners and surgeons, where patients come in. Again, they fly in from all over the country and New Zealand. They're assessed whether they're eligible for liposuction surgery for advanced lymphedema, and we follow Professor Bråsen's protocol from Sweden, or they may be assessed for lymphovenous anastomosis or lymph node transfer surgery, microsurgery by our plastic surgeons. So there's a lot going on in our clinical team. We hold an MDT meeting, a multidisciplinary team meeting on a fortnightly basis. Tomorrow morning, we'll all be there together, where we discuss the patients coming into our surgical clinic. We can link in with local therapists from all over the country now via Zoom, that they can link in if they refer a patient to hear the discussions. We go through the imaging of the patients presented to us. We look at their objective measurements if they've been seen in our clinic before, and we talk about whether they meet our eligibility criteria for our surgery. You can see here in our really fantastic education space that when we have running our education courses, we also bring our students into the MDT meeting so that they can see the lively discussion. And it's been really interesting that running these meetings for over 10 years, our team's knowledge and expertise in this area has increased significantly. And we are now getting more and more complex patients to the MDT meeting discussions. Now, we have developed in 2020, we've formalized some of our research into what we're calling the ALERT data bank. The ALERT data bank is a data registry, and it's a registry that's been set up to collect routine clinical data from the patient coming into our clinic, coming in for the multidisciplinary assessment and management. The data bank was really developed to collect data from research participants either at risk of or living with lymphedema, lipedema, or other chronic conditions. And it's to help us understand factors from these individuals about their changes in their symptoms, their objective changes of their condition over time, whether they have surgery or conservative management, And we also ask for self-reported symptoms, quality of life. We look at treatment costs and management strategies. We encourage recruitment into the data bank when patients come into our clinic, and our research staff invite patients to participate in the data bank and consent to having their routine clinical data collected. We use this data and collect it on a REDCap data management system, and we've got over 800 patients now who have been consented onto this data bank since the middle of 2020, and that was during COVID times, and we're ongoingly recruiting to that. What happens with this data is that this helps us to analyse what is going on to these typical lymphedema, lymphoedema patients who sometimes might not meet criteria to be part of a randomized controlled trial or other formalized research study. So this is very rich data to us that by collecting it, having 800 patients now over 2 years, we're starting to see a whole lot of information and outcomes that we wouldn't have collected before if we didn't formalize it in this manner. The data would have just been in the individual's medical record, which would have been really hard to go back and audit over time. So I'm very grateful to my team who have worked really tirelessly to be able to identify a minimum data set to collect data. And then the importance is of collecting this data, making sure the data is checked by another researcher, that it's clean data, so that when we go to analyze it, we've got really good data to be able to write up publications, which then also feeds into our education program. So these are some of the objective assessments that happen in our clinic. And I guess one of my observations over 30 years of working in this area is there is no one tool to assess lymphedema or lymphatic disorders. And I think there's lots of debate in the literature about how do we assess lymphatic disorders. And I've come to the conclusion that every tool that we use for assessment is important. Every tool is measuring some aspect of the lymphedema or the lymphatic disorder. And we really need a combination approach. And I think we need to move away from thinking that one assessment tool to be quick and easy is the be all and end all. And I think we can't underestimate the importance of self-report and listening to what the patient is telling us, because they are the ones living with the condition, they're the ones understanding the condition, and that is really important to be listening to the patient, as well as these low cost and sometimes high cost imaging assessments that build on our knowledge, but sometimes we need to put it as a package together to understand the whole picture of this condition. So how have we implemented models of care in Australia, in Sydney? And I think it's really interesting that we're all about wanting to get positive outcomes for our patients. We want our patients to feel better. We want to improve the condition that they're living with. We want them to live healthier and better lives and have better quality of life. But I think I chose this picture because it is quite complex. And I think that's why I like working in the area of lymphedema, because it's not a simple thing. And if everybody was going to get the same treatment and the same protocol, that would end up being quite boring. So we need the complexity of individuals coming into this picture. We need to work out which assessments we use for an individual. We need to determine treatment protocols that we will use for individuals, but we also need to understand that some people might not always fit the best practice treatment protocol. And how often have we had someone come to you and say, well, I've got lymphedema, but there's no way am I going to wear one of those compression stockings, when we all know that compression is one of the key treatments that gives a positive outcome. So it's working with the individual, and this is what we're about, looking for outcomes. And I think we need to work and talk about goal setting for our individual patients. As I've said, we've got lots of evidence from very hardcore, high-class RCT research systematic reviews, meta-analysis, we've got the very formalized, but we've also got the clinical practice and the evidence that we gain from extensive periods of time working as a clinical practitioner. And I think we've got to bring both of those together so that we can ultimately give the best outcome for our patients. I think it's really important, as I've said already before, to have person-centered care at the center of our practice. We need to be respectful of and responsive to that individual person coming to see us for advice, education, and management. They will have individual preferences, needs, and values, and we need to ensure that our client values guide and help us in our decision-making. Likewise, I think understanding each client as an individual with distinct beliefs, values, behaviours, and requirements is really central to the person-centered care. Now, some of this might seem really basic, but when I reflected on how do we manage this condition, these are the things that we've got to have underpinning and building the foundations of a program. Anyone can learn how to bandage someone, but you've got to have these core underpinning skills as your foundation in assessing and managing lymphatic disorders and any condition, I believe. So our practice must be accommodated to the wants, needs, and reasonable expectations of the individual. As health professionals, I think we've got to be also conscious of our own culture and beliefs and ensure that we respect the beliefs and cultures of others. And we are living in a very multicultural world these days. And I think we've got to learn to foster cultural respect and inclusion and provide culturally appropriate services is really essential for reducing health disparities and improving access to healthcare in order to respond to an individual's needs. Now, goal setting. This is something that's really important in a lymphatic diseases population, because a patient told me many years ago that you therapists get very excited if my volume reduces or my circumference reduces by 2 centimeters at different points along my arm. But to me, I still have a big, heavy arm. And that hit me many years ago when that lady said to me that we've got to be thinking about what is the goal of the individual patient. And our objective data and our objective outcomes may not meet the goals of the patient. And so I think it's really important that we establish what are the goals for the individual patient prior to treatment so that we can form our treatment plan based on the individual goals. And again, we probably did this in our basic training as a health professional in our own discipline in 101 many years ago for a lot of us. But I think it's really important to have appropriate goal setting, which can help then with client motivation and adherence to the treatment plan that we work through together. And I think we should have SMART goals, that the goals should look at impairment levels. They should look at activity levels, that the patient wants to engage in a particular activity, or participation. We want a patient to play sport with friends. So what are the things that we need to do in order to allow that to happen? Goal setting is important. And these are the things that underpin our model of care at LE&RN. Then I refer always to our toolbox of CDT or CLT treatment. As a lymphedema therapist, there are a vast amount of tools out there. I think we start with our CDT of our skincare, our education, manual lymphatic drainage, compression therapy, and exercise. They're the core CDT treatments. But as we know, with research growing, other technologies, other treatments evolving, there is a range of treatment tool options for our individual patients. And I think we have to always remember to offer our patients what we think is best practice to manage the condition that they're presenting in front of you. But sometimes you might need to modify your treatment in order to meet the individual patient's goals or their lifestyle. So we know CDT treatment can be pretty intensive for a lot of people if they're doing an intensive-based treatment. We know the benefits of exercise, and we can't stress that enough these days, particularly in the cancer rehabilitation space. But in lymphedema, as soon as you move, you're going to help pump the lymphatic fluid, and that's what we're aiming to do. And I think it's really important to ideally have where you're ultimately wanting to get to in relation to compression therapy and in relation to manual lymphatic drainage. Now, I'm aware there's lots of mixed evidence in the literature about manual lymphatic drainage, and I know there's been some highly regarded randomized controlled trials saying manual lymphatic drainage is not effective. We've also got some other work developing that manual lymphatic drainage in combination with other components potentially is beneficial for patients. So I think it's a space we need to talk about and work together in. We don't want to throw the baby out with the bathwater when we're talking about treatment, and we need to be collecting data to be able to see what are the outcomes. And it's quite hard to individually pick out the benefits of all of the components of CDT treatment when often the treatment is combined. As I've mentioned, we offer surgical treatment at our ALERT program. We offer microsurgery treatment, LVAs and LNTs, and we also offer liposuction surgery. And I must say, surgery is not for everyone, and we know that. But I could say to you that I was a skeptic for surgical interventions. Over 10 years ago, I thought, why would someone want to go through surgery? It's not going to cure the underlying lymphatic disorder, not going to cure the lymphedema. And in the case of liposuction, those individuals are going to be wearing compression therapy 24 hours a day for the rest of their life. So why would they do it? But I must say now, after working in our program for 10 years and offering surgical options, that I'm a real convert to surgical management of lymphedema, only to the carefully selected individuals who meet our criteria, who are committed to undergoing our surgical protocol and who follow the protocol with the support of our team. So we've actually found those undergoing surgical management almost become more super adherent and compliant to conservative management after they've invested time and energy into a surgical management program. And I think that it's really important that as a surgical multidisciplinary team, we have to guide and support our patients. We often get phone calls from patients or therapists saying, my patient's had surgery, but we don't know what the post-surgical management plan is. We need to follow these patients and we need to support them as they go through the post-surgical management journey. So now I'm going to just share with you for a couple of minutes how we've integrated some of our research into our clinical care. And I have to say that I have shared some of this research with some of you at other forums, but I'm giving it a different slant today, looking at how we integrate it into a model of care, into translational care. So these are the areas of our ALERT translational research, and these are the priority areas that we've identified strategically in order to move forward and not get distracted by too many other things. So we sometimes get excited that we need to do it all, and we've had to pare ourselves back to say, no, we need to be focused so that we strategically achieve our plans. So many of you may know we have the expertise of Associate Professor Hiroswamy, who came to us from the MD Anderson Cancer Centre and introduced ICG lymphography into our clinic. We initially started using ICG in the surgical clinic only, and then we've broadened it now to our diagnostic clinic. And we use the MD Anderson staging system in our ICG diagnostic clinic. We have published our protocol for injecting the ICG dye into arms, legs, into breasts, and then we monitor the dye binding to the lymph fluid moving through the superficial lymphatic vessels. In our protocol, we initially monitor these individuals for about 20 minutes or so to see how the dye is moving itself. Our lymphedema therapists will help move that fluid through the system. And then we take photos and data collect where that fluid is moving to. What compensatory drainage regions is the dye moving to? It's quite fascinating and been really empowering for individual patients to see what's happening underneath the skin for them. So we've reviewed a sample of our cancer patients, 499. So you can tell this is real data. I didn't make it 500. This is real data from our clinic that we analysed at the end of last year. Majority of them upper limb 367, lower limb 132. You can see majority of them were female in both upper limb and lower limb, and majority of them were unilateral lymphedema in their late 50s is the mean average and being slightly overweight. You can see that in our upper limb patients, majority of them, 93%, were from breast cancer. And with our lower limb patients, it's a combination of gynecological cancers, skin cancers, and others. But interestingly, 90% of them in these patients that were coming to this clinic were coming with clinical lymphedema, and they were in the high risk group because they'd had lymph node dissection surgery as part of their cancer treatment. You can see their range of their BIS, the bioimpedance spectroscopy for patients, and their volume difference, the mean and the range there, and the mean and range time of living with lymphedema. So you can see here from our research, what we've done is we collected this data in our routine clinic, in our ICG diagnostic clinic, and then what we've done is we've mapped the drainage regions of where the lymph fluid went for both our upper limb cancer patients and our lower limb cancer patients. And for our upper limb cancer patients, we've identified 5 drainage regions of where the lymph fluid went to. So the ipsilateral axilla, the clavicular, parasternal, contralateral axilla, and parascapular. If you look on this table, it's a little bit of a busy table, but hopefully I can explain to you. What we've got down here is the MD Anderson staging. We've got the number of limbs and across the drainage regions. And what you can see is that the majority of patients, 80% of patients with upper limb lymphedema drain to the ipsilateral axilla area, the drainage region, which in the past, when I trained to be a lymphedema therapist, was told you don't need to bother draining there because they've had a lymph node dissection. So interestingly, our patients are draining there. As the stage of lymphedema increases, then we get a greater amount of drainage regions. But interestingly, we had 0% in all of our upper limb patients draining to the ipsilateral inguinal region, which is where I was trained to drain fluid to in the past. So just in summary of that table, this is the summary overall of the drainage regions for the upper limb patients after cancer treatment. So this, collecting this data in our routine clinical practice has now helped us to manage our patients in the clinical setting, advising our patients for self-management, advising them about their garmenting. Compression garmenting has really changed by the way we have done this research. And I'll explain a bit more of that when I get to the legs. With our lower limb patients, and again, these are our secondary cancer-related lymphedema, we actually identified 8 compensatory drainage regions. And you can see them there, the ipsilateral inguinal, lower abdominal, upper lateral thigh, contralateral inguinal, popliteal, posterior thigh, gluteal, and axilla. So they were the 8 drainage regions that we identified when we conducted our protocol, which has been published, of injecting the ICG dye. You can see by the table again with the MD Anderson stages that in the early stages, of these patients, they're draining to the ipsilateral inguinal region. And in fact, 61% of these patients were draining there. But in our cancer patients, we had 25% in this sample draining across to the contralateral inguinal region. And this is something that is different for us comparing to our primary and non-cancer related lymphedema. So this has in turn changed our management of our lower limb cancer related lymphedema patients. You can see the summary to the various drainage regions here. In our earlier sample, we identified up to 30% going to the opposite the contralateral drainage region, but the numbers when we added more went to the 25% or so. So this is our report that our patient gets and goes to their therapist or medical practitioner. But interestingly, the garmenting is the thing that's really made a big impact to our clinical work. Excuse me. So for our cancer-related patients, they were often patients that had been previously prescribed in being fitted with a thigh leg compression stocking. So just to go up to the thigh. And if you think about some of your cancer-related patients who may be in thigh leg garments, have a feel and a look at their abdomen region, their genital region, and their buttock region, and also the top of the thigh where the stocking finishes. These are the type of patients that in the past, I would have called that they have a bit of a muffin top at the top of the thigh garment, because the garment is moving the fluid up, but their particular drainage region might go across to the contralateral inguinal region or up into the buttock region, into the gluteal deeper entry point. And so what we've actually found is by prescribing garmenting to also take and support the fluid going in that way, we're now reducing that firmness, muffin top feeling in the top of the thigh or buttock region. So it's really translated what we've collected over a number of years to be able to then make changes to our clinical practice, which also then makes changes to how we teach our health professionals who are learning to be lymphedema therapists. So just with our ICG findings, it's been really useful to do an ICG in the outpatient setting. It's not just useful in a surgical setting. We've been able to identify the drainage regions and areas of congestion to help us personalise lymphedema management and care. Interestingly, the majority of our cancer upper limb patients drain to the ipsilateral and clavicular region and not to the inguinal region on the same side. And our lower limb patients, they drain to the ipsilateral inguinal, followed by the popliteal and the contralateral inguinal for our cancer secondary related lymphedema. I think it's really important to be thinking about your compression garment prescription, thinking about the type of garment, the type of fabric you use, circular knit or flat knit. We're big advocates for flat knit garments, the class of compression you use, using overlapping garments, and the style of the garment going towards where the drainage region we think is for that individual. And that comes also after you assess the tissue. It also plays a really important role in personalising management. And it's helped us also in our MLD and draining the fluid to the particular compensatory drainage areas that have been identified on the ICG. And we're doing further research to explore the longer term outcomes of ICG and MLD in our clinic. But these results have been translated into our education and feeding back into our clinic, which is all about this translational multidisciplinary program. And so just to finish, in the last couple of minutes before I take questions, and please feel free to put any questions into the Q&A box down the bottom, integrating alert research outcomes into an education framework. So how have we done this? So the background for us is that we've been a training provider, an accredited training provider for the Australasian Lymphology Association, which is the peak body of lymphedema across Australia and New Zealand. And they were the accrediting body for various training bodies in Australia and New Zealand. And we had been previously accredited by the ALA to offer training to health professionals. The way we previously did our training was that we offered a combination of an online training program where we used about 70 hours from an online training provider. And then our students came in to do 9 days face-to-face delivery and assessment of their clinical skills. 9 days was a huge amount of time to leave families and workplaces. People were out of the workplace for 2 weeks. Workplaces allowed their staff to come to our centre for 2 weeks of intensive training. These therapists became competent lymphedema practitioners, but there was a huge cost to them personally, and it was a little bit overwhelming and exhausting for everyone. We then had COVID hit, and also along with COVID hitting, the ALA changed its criteria for training providers to meet the accreditation standards. And they developed a competency-based program in order to accredit training providers. So we completely redesigned our lymphedema training program during 2020 into what we've called a micro-credentialing framework. And this has now been formalised through Macquarie University, so as an academic university, and I'm pleased to say that we're the only program that has been accredited by the ALA, but also formalised as a program through a university in Australia. So what we've done to meet the ALA standards and the graduate capability framework through Macquarie University, we've rolled out these 5 units of study. Initially, foundational units, which are 2 completely online units, Principles of Lymphedema Management and Contemporary Evidence in Lymphedema Management. And then we have regional units. And the regional units are done according to an individual's scope of practice and their desire to what area they want to work in lymphedema. So for example, we can now train breast care nurses to just be an accredited lymphedema practitioner in the upper limb and breast. We can train podiatrists to be an accredited lymphedema practitioner for the lower limb and genital region. And we can train a speech pathologist to be an accredited lymphedema practitioner for the head and neck region. We also train, and the wider population that we train are occupational therapists, physiotherapists, registered nurses, medical practitioners, to be a complete lymphedema practitioner across all of these modules, and they complete the 2 foundational units completely online. And then the regional units, they're a hybrid. They do about 50 hours online, and then they now come to us for 2 days of face-to-face learning for each of the modules that they're doing. So if they're coming to do upper limb and lower limb, they're with us for 4 days, 4 10-hour days of intensive learning. So this completion of this does give them accredited lymphedema practitioner status through the ALA, and also these health professionals can then go and practice within their scope of practice as a specialist lymphedema therapist. We've also developed specialist units, or we're developing specialist units. We've developed a unit management of wounds in people with chronic edemas that we've rolled out. Students do part online and then 2 days in person with us. And throughout the rest of this year, we're developing our final 2 units in order to then offer students to be able to complete a graduate certificate in lymphedema management, which has been approved by our university and will be rolled out in 2024 next year, which we're very excited about. And so just to show you the online learning modules that we've completed. So we've used this in a learning management system that the university uses. The You can see here just a snapshot of the online learning. It's very fresh, it's very clean, it's very interactive. The students work through these units at their own pace. Many of our students are doing full-time work and doing this in their own time. Some of our students are working part-time and then have young families. So the idea is that they can work through this online study in their own pace. We also developed online clinical skills videos that we had professionally filmed so that our students have access to these prior to them coming to our face-to-face. So they can be practicing the clinical skills that they need to be assessed in before they come to us in person. And when they come to us in person, they're getting feedback on their clinical skills, and it's our role to assess them to ensure that they're going to be safe and competent in being able to practice these skills in the clinical setting. So in the past, our old model of delivery, we gave some lectures, and these are a couple of the lecture slides that we previously used. We don't give any lectures in person, and anything that we use as videos on our online learning is less than 7 minutes, because 7 minutes is the number of concentration from adult learners. So we want to keep people moving. So throughout our online learning, there's interactive activities. So we might have a little video and then we'll have a quiz. In this case, we've got a little knowledge check here that the student has to be engaged and move things around to assess their own level of knowledge uptake, and also ensure that they feel like they're taking it in and they're competent. So little knowledge checks along the way. For example, in our head and neck module, to look at a picture or a slide of the anatomy of the head and neck like this looks very overwhelming to me. So instead of putting this on a slide and getting our students to rote learn all of the different anatomy components, we've now developed a knowledge check that the student identifies the key things that they need to know as a lymphedema practitioner, and they move them around and put them in order of where they go. They press submit, and if they've got any wrong, they've got the opportunity to go back and do it again. All of these opportunities, the students have access to the modules 4 months before they come to us in person, and they have access to it for another 3 months afterwards. Again, a slide with a whole lot of detail and heavy content on compensatory drainage patterns. And now we've developed animations with support of our learning and development team, developed animations that have little videos of audio speaking what this is talking about, that the students can understand. They can go over and over them. They're fun, they're interactive, and have just taken our learning to another level. And the feedback has been really positive. With our clinical skills videos in the past, we would have a group of 24 students all standing around watching our trainer demonstrate how to apply a multi-layer bandage. Now these students have access to the clinical skills videos. They're captioned, they're time stamped, so students can go back and look at them.
Always opening the bandage.
And we play these skill videos also during our courses, so that the students can have the video playing and they can work to the video timing as well. So they can be in time with the video. And now we as trainers can go through and help them and guide them and give them feedback on their skills, rather than having them all around a big room watching. We've had really good feedback about our courses. We've addressed the learning needs and had a very high satisfaction rate. The impact on their learning has been really positive. So finally, I hope that what I've tried to share today is that implementing models of care that are underpinned by evidence-based practice, working within a multidisciplinary team approach, identifying the skills and the abilities of all individuals, having the patient at the centre, is going to empower both patients, their families, and health professionals to come and work in this area and to be empowered to do the best they can. So I thank you for your attention today. I hope you found this interesting. I welcome you to look at our website. I welcome you to follow us on LinkedIn. And I thank LE&RN for the opportunity of allowing me to present my observations and reflections on my 30-year career as a lymphedema practitioner. So I will open up to questions. I will stop sharing my screen, and I'm happy to stay here for a few minutes till we get to the hour. Happy for further questions, and I think this will be available as a recording for the future as well. So thank you, everyone. So there are a few questions here in the chat, and I will go through some of these questions. So one of the questions is, will these slides be available, or is this published? So yes, some of the work I've presented is published already, and I'm happy to share that. I'm also happy that you could get a copy of these slides. I'm happy to send a PDF copy if you contact me, that would be fine. Implementing ICG in an outpatient clinic, we have been very fortunate to have the skills and the expertise of Professor Hiroswamy. Hiro trained as a plastic surgeon in Japan and then has spent the last 25 years or so of his career in lymphatic anatomy research. He is a bit of a guru in this area and done a lot of research in the ICG area. When he came to bring it to us, we did think we were only going to be using it in a surgical setting until we started experimenting and seeing the wider scope of opportunity. And I think, I'm not sure if this was a question from someone in the United States or not. I think there are people using ICG in the States. I'll do a shout out to the Boston Lymphatic Center, who we collaborate with, but they are using it in a outpatient center. So maybe contact them, but it can be done. You obviously, you know, we've gone through all these approval processes through getting government approval to use the ICG. It's an off-label product in Australia. It's used in a surgical setting normally, but it, you know, we're using it in this way and we have all the approvals. We've also trained 3 of our lymphedema therapists, so 1 OT and 2 physiotherapists, to be lymphedema technicians. And we've developed a 14-week training program to train up our lymphedema therapists to be able to be the technician in moving the camera and assessing the ICG in our clinic. We didn't want to be just reliant on Hiroswamy's expertise, and we've created that competency-based program for that. Someone has said, what about the ratio of success? I'm not quite sure what you're meaning there, but we are collecting data on all of a number of fields that we then have a research question, and then we can go and write a report on the data that helps us then in our publications. We are very interested in looking at the goals of the individual patient and why are they coming to us, and are we achieving their goals? Because like I said, sometimes you as a therapist or as a health professional might think someone needs to be managed in a certain way. However, they're not interested in compression, or they're not interested in exercise, and the only treatment they're going to do is sit with a compression pump. Now, pumps are very effective, but we know that exercise and a combination approach will help someone. But we need to look at goals, and it's really hard sometimes to tease out the individual components of CDT. So that's why we're looking at outcomes, and it's really hard, and that's why there's limited evidence sometimes, published evidence, in the effectiveness of CDT because of the limitations in how do we assess it, how do we measure it, how do we assess the individual components respectively. Just looking here about, someone's asked about self-massage. Do we have any books or videos? No, we don't. We certainly may teach a patient to do self-manual lymphatic drainage of the arm after they've got an ICG map and personalized map of where the fluid is draining, where is the congestion in their limb, and where are the lymph fluid moving, because we know from the ICG that lymph fluid will only move where it wants to move. So we're not taking it anywhere. We're wanting to see where is it going of its own accord. And we use a lot of pneumatic compression pumps for our leg patients. But what we've actually found with the ICG research is we've slowed down the speed of the pumps, and we've used the compression pump degrees of mercury in line with a firmer manual lymphatic drainage technique, because that's where we've identified that a very gentle massage technique absolutely does nothing when you do it under the camera when you've injected the ICG. So how I was trained to do MLD many years ago, when I've done that on a real patient with ICG under the camera, we've actually found that it's not moving at all. The MLD needs to be much firmer and much slower moving through that superficial system in order to see it moving. And when a patient who might have been doing self-massage for a long period of time sees that happen, then that motivates them to do MLD firmer, or to change the way their compression garment is to avoid getting the muffin top, the top of the arm, or if in the arm patient, they've got a lot of congestion there in the forearm, then we want to do extra compression there as well. So it's really helping us to problem solve and identify where the individual congestion area is for a patient, and what strategies, what tools in the toolbox do we need to bring together in order to help them manage their condition to get better outcomes. What am I saying here? Is there a difference between lymph treatment from a physiotherapist versus a massage therapist? Here in Australia, massage therapists can complete training in lymphedema management and can complete a course that does train lymphedema massage therapists. The guidelines that we say is that everyone needs to work within their scope of practice. And that's, you know, for legal reasons, insurance purposes, important. Someone's asked, do we need a referral for our clinic at Alert? If a patient is coming to see a medical practitioner in our clinic, then they do need a referral so they can claim back a Medicare rebate. If they're coming to a conservative clinic, they don't necessarily need a medical referral, but they can use the chronic disease management program to be able to get something back. Can you clarify your courses? Are all the didactic classes online, and some of the practical classes are online? So with our education program, we do have a program called Contemporary Evidence for Advanced Practitioners. And this would be a program that I would recommend to those overseas who do not have access to coming to us in person, although you could make a trip to Sydney and come to our courses in person. The model is that you do the online and then 2 days face-to-face for the body region units. But if you're already an accredited lymphedema practitioner, working wherever you are across the world, you could do our contemporary evidence program, which is completely online. And then we do offer an optional Zoom day, a 6-hour program where you have interaction with our trainers to go through case studies and answer questions about the model, and particularly our ICG research. And we have had therapists from other countries do that. We've had a couple of people from the States participate in that. We've had people from New Zealand, and very happy to welcome people to our courses. And I'd encourage you to go to our website and you can see the range of courses, or follow us on LinkedIn, and we certainly advertise and promote our courses there. Please look at the Alert website for further information, or you can contact me or my team, and we would be happy to send out the PDF of the presentation. I'm very aware of time. Thank you for giving me your time today. I hope that was useful to you all. And I think I've answered most of the questions that I can see, and happy to keep the dialogue and the communication going. Thank you, LE&RN, for offering this symposium today, and have a great Lymphedema Awareness Month, everyone. See you again soon.